My time with you today is just to tell you a little bit about what has been done at the state level, what we learned, and as we're continuing to move forward, what we're trying to do around neonatal abstinence syndrome, and then also how that ties in a little bit to ACEs, just because I think that's so relevant. And right now, adverse childhood experiences is a sexy topic that's getting a lot of interest. We've been talking about trauma for years, right? Not a lot of people heard our voice. Now we have this study that really makes it relevant, and we're getting lots more people interested in that. So here in Tennessee, we have a problem. Right? You heard some of the statistics, and I'm not going to reiterate as many of them, but just to kind of go over again what Dr. Patrick told you a little bit, we saw a huge difference in our drug prescription rates for opioids from 2007 through 2011. And when you see them all on one page, you can quickly see that it moved across the state from east to west and really at a very rampant pace. As you heard, we were the top state for prescription painkillers per 100 people. And in 2013, we had 18.7 prescriptions filled per person, and the national average is 12. So what does that mean? I'm a visual person. I like to see that. That means for every single one of us in this room and every Tennessean over the age of 12, 51 hydrocodone or Vicodin pills were prescribed. I didn't take my 51 pills. Did you take your 51 pills? That's a lot of Vicodin pills. 22 Xanax pills for every Tennessean over the age of 12, and 21 oxycodone pills for every Tennessean over the age of 12. That is a lot of prescriptions. We were joking during Dr. Patrick's presentation that, wow, Tennessean, just in general, really do think that if there's a problem, you solve it with a prescription, right? That seems to be the culture. As you heard, we see an increase in deaths in Tennessee. It went from 422 drug overdose deaths in 2001 to 1,263. That's 100%, just a 30% increase over every year. And that's more deaths than motor vehicle accidents or gunshots. So here we were in the Department of Health looking at hospitalizations for NAS in Tennessee. And you could see that there is a sharp incline and starts going up in 2007 and continues to rise to 2012. So for, every 1,000 live births, we saw a large number of hospitalizations. We had hospital discharge data through 2010, and that showed us that there was this sharp increase. That's where we were able to get the data from. And we heard qualitatively from hospitals, especially in the Northeast region, things like, we are busting at the seams with these NAS babies. And we knew that there was an increase in drug overdose deaths. So we knew that there was a problem. And this is the part of public health and just working at a state level that I love is, so what do we do about it? Okay, there's a recognition here, but now how do we begin to address it? What we did not know in 2012 was the number of cases for 2011 or 2012. There's a lag in the hospital discharge data and their ability to release that information. And we did not know what the source of that prenatal exposure was, right? We knew that there were babies getting diagnosed with neonatal abstinence syndrome, but what was it from? Was it from prescriptions that were being prescribed by physicians, or was it prescriptions that were being obtained without a prescription? Was it illegal substances? So one of the things that happened, and Dr. Patrick referenced this, that we were one of the first state to make this a reportable disease. And what that means is all hospitals have to submit electronically a report of any baby that's born with NAS. That was effective January 1st, 2013. And that was one of the ways that we can begin to look at how do we get more real-time data about the children being born with NAS. And so the reporting elements included some diagnostic information, some case information, and the source of maternal exposure. These surveillance summaries are available every single week, usually about Our epidemiologist gets them to me to submit for approval to put them up, and she sends them out about 8:30 on Monday mornings. So if you're not familiar with them, I do have the link at the end of this site where you can look at that. So every week you could see what is the cumulative case of NAS that has been reported, by what area. We can't do county in certain regions, so we talk about our regional health counties, regional health areas, and then the source of exposure. So you'll see that this was the most recent one that was sent out on Monday, and we have 33 cases reported thus far. Now, hospitals do have 30 days to report the information to us, so it's not like exact time, but it gives you a good indication. Here's what we know about the 2015 from the surveillance data. And these numbers are not final because babies born December 31st, technically hospitals have till January 31st to submit that information. So we will have a final annual report around the first or second week in February. But this was what was reported to us as of January 2nd of 2016 about the 2015 cases. And you'll see that there was about 34.3% of cases were using prescriptions without a prescription. So they obtained that illegally. Or that 22.6% had non-prescription substances. And this won't equal 100% because many of the moms have multiple categories. You know, they're reporting that, yes, they were on supervised replacement therapy, and, oh, by the way, they did use prescriptions or something like that. So they're not 100%. But you'll see that a lot of them, 61%, are on supervised replacement therapy. They're attempting, they're trying, right? They're under a doctor's supervision. So it's something that we have to take into account as we talk about neonatal abstinence syndrome. You'll also see by region, this is definitely spread across the state, but 58.5% of cases are in East and Northeast Tennessee. And that's actually down. There was one point where it was about 75% of the cases were in East and Northeast. It's definitely spreading. 24.3% of the cases are from the Middle Tennessee and the Plateau area where you all live and work daily. And for some reason, the west area of our state is not as impacted. And I've had conversations with people just wondering what that's all about. And colleagues from Memphis will say, we just like our weed and alcohol. So, but it's very interesting. I know in 2013, when we first started coming together in Davidson County, and we were looking at, there were 55 cases in Davidson County. I don't have final numbers yet from last year, but we'll continue to watch that. An important caveat about the reportable disease surveillance, it's for surveillance purposes only. We do not get identifiable information on these mothers, right? So I just always say that because we don't want people to think we have this great data file sitting there with all of these things that we can start linking to other files. We don't collect that level of data. This does not constitute a referral to the Department of Children's Services. We had lots of discussion about that. We did not want to make it a barrier for physicians to give us this information. And they really have to go by their regular reporting suspected abuse and neglect requirements for reporting. So a couple other things that are really happening that kind of really kicked off Tennessee to be a leader in neonatal abstinence syndrome was that there is a children's cabinet that was reconvened by Governor Haslam by executive order when he took office, and he and the First Lady co-chair the children's cabinet, and they decided early on that there needed to be a sub-cabinet specifically focused on neonatal abstinence syndrome. So they first met in the spring of 2012. They committed to meeting every 3 to 4 weeks, and you can see the departments that are listed there. It includes health and children's services and education and TennCare, and the Department of Mental Health and Substance Abuse Services. And through those conversations, they really said, how do we look at this across all areas of prevention? We want to look at primary prevention. How do we prevent pregnancy or prevent addiction? How is it that we can look at secondary prevention? Let's screen the women for substance abuse during prenatal visits and refer for treatment. And then, of course, tertiary for those women who are already addicted. How do we treat them and then treat the babies with neonatal abstinence syndrome? So a couple successes from those conversations. So in November of 2012, there was a letter written to the U.S. FDA that really asked for a black box warning to let prescribers and the people who receive the prescriptions know that this is something that can cause neonatal abstinence syndrome. In September of 2013, FDA did do that and released a new statement that says that it basically will have a new boxed warning on the opioid analgesics to caution that chronic maternal use of these products during pregnancy can result in neonatal abstinence syndrome. So that was important. Also, TennCare, as part of their prior authorization forms, included on there specifically for female patients between the ages of 18 and 45. Has the patient been counseled regarding the risk of becoming pregnant while using this medication? And that was an important step to at least trigger the prescribers to have this conversation with women, and to specifically then ask them if they're using a form of contraceptive and have they been offered access to contraceptive services, right? Because if we can get women who are addicted to not become pregnant, then we can eliminate neonatal abstinence syndrome that way. So that was an important step that kind of came out of those conversations. And then, as Dr. Patrick mentioned previously, the Controlled Substance Monitoring Database was written into legislation in 2012 as part of the Prescription Safety Act. It was an interesting process to get people to begin to, one, be required so that if I'm going to see you in my clinic and give you a prescription, I'm going to look to see, have you also received that same prescription from another provider? And at the pharmacy level, as a pharmacist is giving that, they double check to make sure. And what that does, as we looked at the kind of the first year, was that there was a 50% decrease in doctor shopping. And that 73% were more likely to discuss substance abuse issues with the patient because they were talking to them about, is this a prescription you received recently? If so, how many times? To really get at some of those conversations. I was just looking at the committee that meets to go over the Controlled Substance Monitoring Database regularly, and there are now over 42,000 providers that are regularly using it. So that's a really good sign that it's something that is beginning to become just part of standard practice. And of course, I'm from the executive branch of government, not here to say anything about legislative, except to say that this did get legislative action and attention in a number of different ways. There were a couple in the Tennessee Code annotated, are listed here if you want to look them up specifically, or I can share those with you. But there was a law passed that said pregnant women should get priority for state-funded substance abuse treatment programs. There was part of that law was that a child cannot be removed solely due to maternal substance abuse if a woman is trying to get services before she's 20 weeks gestation. There was some information about people that were at risk of overdose. And the way that they should be treated, allowance for the misdemeanor prosecution, and you talked about that earlier. I can't say a lot about that. Required 2-hour continued medical education on controlled substances is an important part. If you are a prescriber, you now have to show that you've had that 2-hour CME, so that's important. And then there was a 30-day dispensing limit. So if I give you a prescription, you can't hold on for it for 3 months and then go get it later. You have to get it within 30 days. So those are all legislative actions that were taken just as part of this continued awareness and discussion at the state level. At the Department of Health, we specifically started looking at some pilot programs. We looked at how do we do the screening, brief intervention, and referral to treatment expert. Many of you are familiar with that model, to begin in the family planning and primary care clinics across the state in all 95 counties. How do we partner with the methadone clinics to really provide, so you're there, you're getting methadone, and you know what? We have the ability to give you the Depo-Provera shot right here because that is instantly able to then support birth control, and of course talk with you about longer acting reversible contraceptions available through family planning clinics. And this was on the news recently, just a couple of months ago, but to emphasize it is voluntary that we talk to female inmates of childbearing age, and especially if they had a substance abuse charge, to talk to them about long-acting reversible contraceptives that are available to them in their in the family planning clinic, and get that to them before they are discharged from the prison or jail. So those are all ways that the local public health pilots were working hard to try to figure out what is the best way to prevent pregnancy. There was also a lot of work with the Department of Mental Health and Substance Abuse Services so that we did drop-off boxes, get rid of the drugs you have in your house, make sure that we have these take-back days, and really worked hard with the county substance abuse coalitions to get all those prescriptions that we talked about that are sitting out there. How do we, if you're not using those, get those off the street? So that's important. TDH is also did and continues to fund a pilot with Families Free, which is a recovery support and wraparound service model to try to figure out what is the best way to treat and support these mothers who are delivering NAS infants. And that's funded with a different funding streams. And then the Department of Children's Services, many of you should know this. If you don't, though, they have staff positions at two of the children's hospitals, and I believe now just expanded to a third one, to really coordinate efforts between the hospital and the DCS staff around these families. Because there's varying practices across the state about DCS's response to NAS. And so trying to have someone there who can really work with everyone to determine what is the risk to this child and what do we do to best support the family. There were also 5 different grants awarded, some of which Dr. Patrick was the recipient of, to really answer NAS key research questions. Like using Tennessee data and your expertise within 1 year, can you tell us more about, what is the predictive model for NAS? And as you heard Dr. Patrick say, one of the key things that was discovered from that is the connection to tobacco. That's something that we didn't know back in 2012 that now we can look for. Barriers to contraception and women attending substance abuse programs. What is it? Why is it that they do not have contraception? And what can we do to help that? And some of that is what helped us understand that, going to where women are, like in jail, is a better way to get them contraception than saying, come on into the family planning clinics. Optimal management of the pregnant women taking opioids, I still think that continues to be a challenge from what I hear. Lots of different, ways that could be seen. Understanding and improving provider knowledge and behavior, and some of that has led to things like this, which I'll tell you about in a minute. And then understanding the optimal management of the infant with NAS. I oversee a lot of the home visiting and care coordination programs at the Department of Health, and a lot of people are like, what do we do? How do we help this mom when this baby is really having very strong symptoms? So we continue to try to work to say, here is how you manage these babies. And so did a lot of work, but there's still a lot to do. And I'm not going through this. I'm just showing you that there is this continued strategic mapping process going on to say what is the role, and particularly as a public health approach, that we should be doing looking at NAS. And so we're doing everything from trying to improve primary prevention to improving regulation and enforcement, increasing the utilization of treatment to increasing access to appropriate pain management. Because a lot of the pain management clinics, there are certain specialty providers that we say would be the best to be able to open up a pain management clinic, and we're trying to work toward that so that there's some recognition that pain management clinic physicians should have a specialty certification and understand these issues in more depth. At a bigger level, the Children's Cabinet has really decided to dig deep into the idea of service coordination and how to better manage. One of the things that you heard earlier from Jennifer's presentation on adverse childhood experiences is the impact of trauma. I'm very open about this. I talk about this all the time. I have 8 out of 10 adverse childhood experiences. And I share that because people hear about adverse childhood experiences and I think, no, there are lots of ways to mitigate the impact of that and to not contribute to re-traumatizing families. And when we come in and there is a mom who has substance abuse and potentially adverse childhood experiences, we think there's a very high correlation there, and are doing some work around that. How do we not then send 6 different people into their home with 6 different care plans and 6 different goals and expect her to manage all that and her child in order to get the child fully into her custody? We are re-traumatizing that mother. And we really need to be, cognizant of that and come together. And so the Children's Cabinet is working in 2 counties, Knox County and Putnam County, where there were high numbers of children in DCS custody because of neonatal absence syndrome diagnosis, to say, as the state of Tennessee is one enterprise, how is it that all of the different services provided through those agencies are doing a single care and single team approach? And we're we're learning a lot. Knox County has enrolled 5 families in their pilot, and they really are coming together. Knox County is really leading a conversation with families at the table, talking about what their goals are, and every agency is talking about, okay, here's what I have to do for early intervention. However, here's how I can also support your goals. And the beauty of what they're finding is, what are the kind of trigger points that you start seeing mom not start coming to some services? How do you share that information so the team can rally before it becomes, oh, she definitely, has relapsed and started using substances again? And so those are the conversations they're having, and they're learning from each other, and that we'll have recommendations to the Children's Cabinet around November of this year to say, here's what we learned, and here's how as a state we should be changing the way we practice in order to make sure that families are at the table and we're all coordinating services. It was amazing to me to look at one case. We looked at one case in Knox County, and the court-ordered parenting plan is about 30 pages. The TEIS early intervention program was about 12 pages. And I just had a hard time getting through it myself. And I thought, I have a master's degree, and I'm not trying to deal with substance abuse and a newborn, right? So it was really an interesting experience. And I think we're going to learn a lot and be able to kind of give some concrete recommendations. And then here we are together because, as you heard, there were some interested community partners who said, hey, we have some issues in Davidson County here in the service coordination. The Department of Health said, hey, let's give you a little bit of money and get a facilitator in here and pull you all together and figure out what we want to do in Davidson County and Middle Tennessee. And that has led to 3 different design workshops that really kind of came up with a vision. There's going to be a demonstration pilot here that the local public health department is going to serve as kind of a quarterback care coordinator and see how is it we can better wrap services around and get to that idea of a system of care. And so we're excited that, and that's what led to this meeting here today, is those conversations. So we're excited that we were able to kind of be at the table with that. And then the other piece related to that, not specific to NAS, but broader, I think that what we're trying to do is change our culture and change our conversations in our state. So we have the Adverse Childhood Experiences Study. You just heard Jennifer do her wonderful presentation about it. Together we have done over 100 different presentations across the state in the last year about it. Child Advocacy Days in March here in Davidson County is all going to be focused on adverse childhood experiences. There is a lot of excitement when people hear that study because they make some concrete connections. And when I hear the Supreme Court Justice of our state get excited to think about how do we help judges shift their mindset from what's wrong with you to what's happened to you, I think, okay, there's opportunities here for us to change our culture. And so on November 12th, we had Governor Haslam and First Lady kick off our kind of 3-year initiative where we're combining the early childhood brain development with communication science to really come up with a way that we talk about prevention, early intervention, and really preventing trauma and the long-term impacts of that in ways people can understand. We want every average Joe Tennessean on the street to be able to say, oh yeah, that of course that's important. We know that we have to prevent these things early on because it leads to all of these lifelong implications. And so we had more than 250 people there, and it was a very exciting event, including legislators and philanthropists. What that is going to do is really lead us over the next 3 years to look at how do we prevent, mitigate, and treat adverse childhood experiences across multi-sectors and multi-levels. And that begins with philosophy and approach, policies and funding, practices, and programs and services. And so we're really looking at every level, how is it that we begin to kind of change the response that we have in our state to adverse childhood experiences. And we're one of the first states really embarking on this, so I encourage you to stay tuned to that. This is a very complicated and infrastructure diagram, if you will, of how this is proceeding. The major point of it is that one of the things we are focusing on is how do we support community innovations, that we can really support communities to say, here is what we know about our families. As you all are thinking about those women who are struggling with substance abuse and having babies with neonatal abstinence syndrome, what is it that works in Davidson County or in your county in Middle Tennessee? Let's figure out ways to pilot and learn from that so that we can continue to move forward with community innovations. Shelby County is one of the first counties that really started looking at this, and they came up with a very unique idea, and it's called universal parenting places. They have a heavy evaluation. We'll see if it works, but the idea that they have in a variety of different settings in different neighborhoods, these universal parenting places for people to go where they can, there's mental health, there's substance abuse, there's child development specialists, all right there. And so they can come and do a play group or, take out some toy lending libraries, but also then talk and, get some real support at the time that they need it. And we'll see if that works. Will that model work in some place like Campbell County where people have to drive 50 miles to get into town? We don't think so. It has to be very locally driven. But again, part of why this is important to this group is because when we talk about ACEs, the 3 top ACEs that came out in the 2009 and 2012 Burfist survey that we did around ACEs is substance abuse, emotional abuse, and divorce and separation. And so that continues to be the way that we connect ACEs and substance abuse so people understand that. On the NAS main page, you can find more description about the work that we're doing, as well as the weekly surveillance summary archive. You can sign up to get on the email, so it just comes in your box every Monday. And I highly encourage you, if you have any questions, Dr. Michael Warren is my direct supervisor and a leader in the country around NAS and policy development, and you can contact him or myself. So thank you for your time and attention.